For the continuation of the gram-positive bacterial infections, we have the anthrax. The most common pathogen would be the Bacillus Anthracis. This is actually potentially fatal and can be used as a biological weapon. The mode of spread is through the entry of spores, through the break in the skin or inhalation of the spores. It can also be through the undercooked meat when you intake this undercooked meat. Clinical forms would be the cutaneous anthrax. We have inhalational anthrax and gastrointestinal anthrax. First would be cutaneous anthrax. It begins as a painless pruritic papule, meaning painless but itchy papule that develops into a vesicle, meaning there will be fluid accumulation, and then edema. And then ruptured vesicle can cause, very important, plaque eschar covering. So when you see in a question, the patient presents with uh, vesicular lesion with surrounding edema, and the vesicle caused an ulcer with black eschar covering. What is the most common pathogenic? What is the most likely pathogen? It's the Bacillus anthracis. For the inhalational anthrax, we have it is carried by the phagocytes to the lymph nodes, thereby causing hemorrhagic mediastinitis, bacteremia, often with meningitis. So this is the most deadly form of anthrax. So it's actually, there is death after 2 days. Gastrointestinal anthrax is uncommon and usually from the undercooked meat, and then the patient will present with nausea and vomiting with bloody diarrhea. Pathologic finding, you have necrosis and exudative inflammation. There will be presence of large boxcar-shaped gram-positive extracellular bacteria in chains, which is suggestive of anthrax. Gross findings, the lungs would have foci of hemorrhage. This is very important since this foci is hemorrhage is induced by what clinical form of anthrax? By inhalational anthrax. So perihilar and peribronchial lymph nodes are enlarged and hemorrhagic. The lungs would have hemorrhagic lesion associated with vasculitis. So compared to pneumonia, which are within the alveoli, the macrophages are found within the interstitium. In the anthrax, again, the macrophages and the neutrophils are found in the interstitium compared to pneumoniae, which are found within the alveoli. So for mediastinal lymph nodes, there you have lymphocytosis, macrophage, and fibrin-rich edema fluid. This is actually a picture of a fibrin-rich and then present predominant in alveolar capillaries and venues and sometimes in alveolar spaces. Okay, pathologic findings of cutaneous anthrax, there's massive subepidermal edema. This will be the vesicles, and then there will be surrounding edema, as what I mentioned a while ago. Then extensive dermal necrosis with intense neutrophilic infiltration. For the respiratory anthrax, the most common would be Woolsworth's disease. Presenting symptoms would be fever, dyspnea, hypotension, and death. There is, again, this is the most fatal kind of anthrax since there is 90% mortality rate in 2-day duration. Symmetric widening, the cause of death is actually the symmetric widening of mediastinum with mediastinitis. Okay, pathogenesis. Bacillus anthracis produces toxin that has a polyglutamyl capsule that is antiphagocytic. The toxin A and B subunits. The B subunit serves as the protective antigen. Again, whoever has the antibody against the B subunit, it's very important, will not be affected by anthrax. So the toxin has two alternate alpha or A subunits. We have edema factor and lethal factor. When there is a decreased pH of endosome, there will be causing changes in the configuration of in the B heptamer. Both EF and LF are transported to cytoplasm and can affect the enzymatic actions. The EF will bind to the calcium and calmodulin to form adenylate cyclase. And this will in turn convert ATPs to CAMP, leading to interstitial edema. So increase in CAMP is actually caused by what subtoxin of alpha subunit? It's the EF. Well, the LF is the one, lethal factor, it's the one that destroys the, since lethal, it's the one that destroys, and the MAPK, which is very important in cell growth and differentiation. Now we go to Nocardia. Nocardia is a gram-positive bacilli. They grow in distinctive branched. So very important, although not written here, is that they grow in distinctive branched chain. This is actually a distinctive branched gram-positive organism with WBCs. They cause opportunistic infection in immunocompromised patients, and like those patients who have prolonged steroid use and those who are infected with HIV. Nocardia is aerobic, and the diseases caused by nocardia is divided into two because they have two different infectious agents. We have Nocardia asteroides, which can cause the brain abscess, and then the Brasiliensis, which can cause the skin infection. So asteroides actually brain, and Brasiliensis is actually the skin. So one thing to remember, asteroids, think of the neurons as they look like asteroids, and then you can see respiratory infection can lead to what? Brain abscesses. Brasiliensis, I use the mnemonic BRA. BRA is the one you use to protect your skin, specifically your breast tissue. So this is for skin infections. And then they will present with suppurative inflammation, suppurative because they are aerobic. And then there are granulation tissue formation and fibrosis. That's all for gram-positive infections, bacterial infections.